So this talk is going to be about an update on our algorithm for psychopharmacology of PTSD, which we just recently updated and published. These are my affiliations and disclosures where I work at the VA Boston Healthcare System in Boston. And I do get no income or support from any pharmaceutical companies, and I do have royalty income from 2 books. So for this talk, if you'd like to, just open your mobile phone's browser to our website where we have all of our algorithms. The website is psychopharm.mobi, M-O-B-I, and this is what it looks like when you go there. And if you see the top, there's a menu of algorithms. If you click on that, the list of algorithms on our website comes up. We have 14 of them there now. 11 have been published in peer-reviewed journals. 3 are under construction, and we have them up there to get feedback from people on what people think of it so far as we prepare the drafts of papers to submit for publication. So for example, if you want to see the PTSD algorithm circled there in red, you would click on it, and then this shows you the flow chart, the overall flow chart of the PTSD algorithm, and you can pick a size, either smaller or larger at the top there. If you pick smaller, you're looking at it right now. If you pick larger, then you can see a smaller portion of the flow chart. And then what happens is you find where your patient is that you want to consult on, and then you click on the box for the clinical scenario of that patient. Let's say you're at the point where you've decided to try prazosin. So then you would click on the try prazosin box, and then a little text will come up showing the discussion of why we are recommending prazosin at that point. It's a very abbreviated discussion compared to what's in the published paper, but it gives you a quick reminder of what we said about that. And there are a few references in each of these boxes. There's way more in the paper, but let's say you wanted to see reference 1, which is circled in red there. You would click on it, and it brings you directly to the paper in PubMed. And sometimes you can actually get the full paper if you have privileges to get that in PubMed. Otherwise, you get the abstract. So that's how you work our website to see our recommendations on the different algorithms. This is a list of the peer-reviewed algorithms that we've had with the last year that they were published. And you can see that PTSD is the 3rd one down. That was published last year in our latest revision of it. And I've done a little further revision for today's talk. Okay, so to introduce the PTSD algorithm, I'll just make the general comment that PTSD is associated with dysregulation of neurotransmitter, neuroendocrine, and neuroanatomical systems in the brain. And thus, pharmacotherapy would seem to have a potential role. But I want to stress very strongly, I hope everyone's listening right now because I always get questions on this. We do consider psychotherapeutic modalities in the treatment of PTSD and all the other conditions for which we have algorithms to be very important. Medication is not even necessarily first line for PTSD. And the point of our algorithms is not to bring together all of the evidence on all the different kinds of treatment for these conditions, but just to assist you with your choice of medication if you and the patient decide you want to use medication. So please don't misunderstand and think that we advocate medication exclusively or initially for everyone. Not at all. Now, the core groups of our algorithm teams that we assemble to build and write up and submit these algorithms has a number of core values that are important in the development of these algorithms. First of all, efficacy is extremely important in determining the order of sequence that we recommend, but also safety is given equal consideration, both short and long-term safety. So you might have a drug that's more efficacious, but whose long-term safety is inferior to other products, and then it'll be lower in the algorithm. For example, in our schizophrenia algorithm, we place olanzapine lower because it has longer-term safety problems, even though it may have a slight edge over other non-clozapine antipsychotics in terms of efficacy. The second bullet about our methods is that knowledge of the evidence base when you make a clinical decision is necessary but not sufficient for clinical decision making. There will be instances where clinical judgment justifies deviation from the recommendations you're going to see. But we do think that you should tank up your brain with what the evidence suggests may be best as an initial step in making your decision, and then see if there are other considerations that might lead you to either follow what the evidence seems to point to or do something different. Another key value is we want to submit our algorithms for blinded peer review because they're opinion-based distillations, qualitative distillations of the evidence base. That's what they are. So we really want some other experts to see our reasoning, see if they agree with it. And in the peer review process, when we publish, we get very substantial feedback from experts who are sent our papers because we're doing a very bold and ambitious thing to suggest how the overall psychopharm treatment should go. So other experts will definitely be eager to criticize it if they think differently or they interpret the evidence differently. So they let us know that, and we have to achieve consensus with those reviewers before the paper is going to get published. So that's a very important process that I think anyone in the algorithm business should be endorsing, to have peer review, blinded peer review of your algorithms. All right, the second few points I want to make by way of introduction is that there are only 2 FDA-approved meds for PTSD in the United States, those being paroxetine and sertraline. So as such, most other recent algorithms and guidelines recommend SSRIs as first line for PTSD psychopharm. But we focused on the quality of evidence that supports these SSRIs that got that approval and other medications that are being used. And that led us to propose a treatment sequence that actually starts with something different, usually prazosin, for treating the sleep disturbance that's invariably present. Over 90% of people with PTSD have significant sleep disorder. So this is core to the clinical manifestation of PTSD, and treating it with something with known effectiveness for sleep may have downstream potential to help their daytime symptoms as well. And also prazosin has been used in the daytime to help those symptoms additionally. So we came up with, I think we're the only significant guidelines saying that prazosin is your first-line treatment for PTSD. And our reviewers agreed with us 3 times that we've published a paper on it. All right, this is the overview of the algorithm. I'm going to go through it step by step. You probably can't see it very well if you're seated in the back, so don't worry about that. I'm going to explain each step, but just overview. It starts at the top with making a diagnosis, assessing for comorbidities, and then if they have certain comorbidities, there are deviations from the usual algorithm that will be important to keep in mind. And then after that, we assess sleep. Is sleep disturbed? And if it's the typical abnormalities in sleep seen in PTSD, like nightmares, disturbed awakenings, night terrors, then we do recommend prazosin as our first-line treatment. But if they don't have those kinds of problems and they only have trouble falling asleep, then we have some different, we recommend hydroxyzine or trazodone or clonidine. Anyway, more on all of that later. After treating the sleep, you're at the bottom of this flow chart. That's when we recommend considering an SSRI for whatever symptoms might be remaining of the PTSD that still need treatment after you've managed the sleep problem. And this goes to some more details of what happens after that. If it's psychotic symptoms along with the sleep problem, then we will suggest adding an antipsychotic. And if not, on the left side, we have our second recommendation of an antidepressant and our third recommendation if the first two fail. And then at the end, we have some other things to consider that aren't in the mainstream of the algorithm, that are up and coming or potential possible future important treatments for PTSD in the somatic therapy realm. Okay, so let's go back and look in more detail at these sequence of steps. So we'll start with node 1, which is the diagnosis of PTSD. So we go by the DSM-5 criteria, of course, but there are important comorbidities that we want to be sure are, whether they're present or not, because they could lead to a change in the basic algorithm that I just showed you. So we first ask during the diagnostic process that you delineate these other diagnoses, and I'll have a slide on each one to show you how they would change the algorithm. But they are substance use disorders, depression, bipolar disorder, psychosis, and women who have the potential to bear children. So starting with substance abuse, what would we do differently? Well, we don't recommend benzodiazepines in the algorithm as a whole. However, lots of people use them. But you should particularly avoid them in women of childbearing potential because of their potential teratogenic effects. Dizipramine has one small positive study with alcohol use disorder comorbid with PTSD. The dizipramine had no benefit on the PTSD, but it did seem to help the alcohol problems in that population. So for the sake of completeness, I mentioned it. It's not a major option. The third consideration is topiramate, which has been found helpful, versus placebo, also in a study of alcoholics with PTSD. Now, prazosin. Let me also mention that prazosin has been used for alcohol use disorder. You'll be hearing much more about prazosin a little later. But under this comorbidity, if it's present, there have been a number of studies trying to assess if prazosin has a role. So you'd think maybe it has a special role for alcohol use disorder patients who also have PTSD. So what do we have for evidence? Well, one study showed that prazosin may attenuate cue-associated alcoholic craving. The cues being cued PTSD issues that leads them to want to self-medicate with alcohol, or anxieties of a PTSD nature connected with those triggers or cues. That's a group that may respond to their alcohol use disorder with the use of prazosin. And then another study found that patients display more intense withdrawal at study onset. The ones displaying more intense withdrawal demonstrated the most benefit from prazosin in terms of reduction in drinking. So prazosin is a particularly interesting option, even if there's comorbid drinking. Interestingly, previous studies had suggested prazosin is not effective in PTSD patients who are actively drinking now, but the newest study by Raskin and colleagues, just published this year, found significant benefit for the alcohol problem, preventing future and increased alcohol use in the group who had the hyperadrenergic subcohort of PTSD, the ones who had high blood pressure. Again, I'm going to say more about this shortly. But the subgroup of alcoholics who had the hyperadrenergic type of PTSD responded better to prazosin than placebo for their alcohol use problem. So it's an interesting area where there's a lot of active research going on right now. Next comorbidity to mention is major depression. It increases the risk of developing PTSD. And if you have major depression and PTSD, antidepressants work even less well than they work in people who don't have depression, which is the opposite of what you'd think, right? You think, gee, they've got major depression, that responds to SSRIs. They've got PTSD. We have 2 antidepressants with FDA approval, 2 SSRIs. So what if they have both? Well, they respond less well. And actually, it's a common issue in psychopharmacology. The more comorbidity you have, along with the primary problem that you're trying to treat, the less likely you're able to get the usual better response when that problem occurs as a mono problem, not complicated by comorbidities. Now, what about bipolar disorder as a comorbidity? Well, it's a very common comorbidity in the patient population I work with which is veterans of the U.S. Army and Navy services. And they often have PTSD, and there's a goodly number of them that have bipolar as well, certainly as many as in the regular population. And this turns out this combination of problems has a significantly elevated risk for them to occur together. So what do we recommend? Well, first of all, since it's bipolar disorder, we generally don't recommend antidepressants. They're not proven to work. They have significant harms that are associated with them in some cases. So even though they may have FDA approval for PTSD, if they've got bipolar also, we definitely would avoid them where they come up in the algorithm. Let's see, what happened to my clicker? It's not taking me to the next slide. Help. The clicker has just gone down. Oh, it just clicked. It just worked. Okay, I think did I skip a slide? I guess I could go back. Yes, psychotic symptoms and PTSD. That could indicate a comorbid psychotic disorder, or these could be PTSD-related psychosis. I'll say more about that when it comes up in the algorithm, but if it's a PTSD-related psychosis, consider skipping the sleep phase of the algorithm, move directly to an SSRI, and you may need to add an antipsychotic. For people who are at risk of becoming pregnant, we would avoid paroxetine among the SSRIs, even though it's one of the 2 FDA approved. It has a Schedule D rating from the FDA due to risk of fetal septal defects. Fluoxetine also may have comparable risks, though the FDA did not give it a D rating. Okay, so that's the diagnosis part. Moving to the second node of the algorithm, which is assessing sleep. So the first step with people who are not sleeping well is to do a thorough review of the differential diagnosis of insomnia, because they certainly could have other causes beside their PTSD. They could have sleep apnea, very commonly seen in our veterans. They may be drinking way too much coffee. They may have sleep hygiene issues. They're just not going to bed in a proper manner and timing. They may have restless leg syndrome. They may have medical problems associated with sleep fragmentation, like pain, nocturia due to urinary issues. Nicotine withdrawal is a common one that wake people up at night. A heavy smoker doing a pack a day, and then they stop smoking, of course, when they go to sleep, but then after about 3 or 4 hours, they wake up. And what's going on? They find that they go have a cigarette, and then they can go back to sleep. So what's going on there? Nicotine withdrawal, probably. They just sort of automatically go have a cigarette, and miraculously they can now go back to sleep. So what's the treatment for that? Not all these other things I'm talking about in today's lecture. It would be to find a way to quit their nicotine habit. So having ruled out those other, or treating those other causes of sleep problems, you now are ready to assess the PTSD-related problems of sleep, and they are of several types. First of all, there's hyperarousal-related difficulty initiating or maintaining sleep, or commonly both. So what's keeping them from, what's causing these awakenings? Trauma-related nightmares. Anyone who tells you they're having nightmares, at least suspect PTSD, if you hadn't already. Determine the content of the nightmares, and that may lead you back to whatever the trauma is that caused the nightmares. It may well be revealed in the content of the nightmares. The second is disturbed awakenings without recalling a nightmare. This is a routine question you should always ask anyone who you're evaluating for nightmares or for PTSD, because many patients just don't remember their nightmares, but they wake up in the middle of the night, or they wake up at an early hour in the morning, 4 or 5 o'clock, and they just can't get back to sleep. They're all anxious, perspiring, hyperventilating, heart is racing. They don't know why, but they can't get back to sleep. They may be up for good. This is called a disturbed awakening. This is a target symptom for prazosin. So you definitely want to identify if it's happening. Don't be satisfied with just asking about nightmares. And a third type of problem is night terrors. That's when they, in the middle of their sleep, they're yelling and screaming. Maybe they're thrashing about in their bed. Maybe they're choking their bed partner in their sleep, and they don't remember any of this. If you wake them up, they remember none of it. But it can be very frightening to whoever is observing them, and we term those night terrors, and they almost always are due to PTSD. Okay, so having now diagnosed that they have PTSD-related sleep problems, is sleep disturbed, and it's due to the nightmares and disturbed awakenings, we're recommending prazosin. What is prazosin? It's a non-sedating, and this is important to mention that it's non-sedating. It doesn't particularly help you to fall asleep. So it may be necessary to add something to help them fall asleep. The main use is to stay asleep. And why does it work? It seems to be the best drug of that class of drugs, prazosin, doxazosin, terazosin. Uniquely, prazosin crosses the blood-brain barrier, gets into the brain, and has its antiadrenergic, anti-adrenaline effect there where it's causing the PTSD symptoms and the sleep problems. So that's the theory behind why it works and other drugs in its class do not. There have been 9 placebo-controlled trials to date of prazosin, of which 6 were positive. Many of those were with quite large effect sizes. There was a meta-analysis just this year of all those studies, finding a positive effect size, and it seems pretty clear from the evidence that it works, and it's probably our best treatment. Nothing seems any better. It's well tolerated, even at relatively high doses in the elderly. I often get asked, gee, can you use it in the elderly? You know, won't they have low blood pressure and so on? Well, it seems that you can. And Raskin has done this quite interesting work to see if he can find predictors, because as was stressed in the last lecture on antidepressants you just heard, for every drug, and prazosin's no exception, there are responders, there's non-responders, and people who get worse on it. And that's true of prazosin as well. And what predicts response? It seems that high blood pressure predicts response to prazosin. And Raskin has termed that the adrenergic subtype of PTSD. So be on the lookout for who's got high blood pressure when you are about to treat their PTSD, because the adrenaline that's in the periphery causing the high blood pressure, it's probably the same adrenaline that's causing all the PTSD symptoms in the brain. Now, they may already be on drugs for high blood pressure, so you may have, then their blood pressure right now may be normal, but your key will be knowing that they need 2 or 3 drugs to control their blood pressure. So, and you're going to start another drug, which is an antihypertensive. So you need to be aware right from the beginning that you may need to reduce or discontinue one of the other antihypertensives to make room for the prazosin trial. It's by no means a reason to avoid prazosin, if that's the case. Now, just to review some of those impressive results on the earlier prazosin trials, look at these effect sizes by Cohen's d in red on the right-hand side. In these 3 small studies, we're talking about 1.9 effect size. We never see that in medicine, in psychiatry, for anything else we treat. 1.6 for trouble with sleep, clinical global impression of 1.4 by Cohen's d. We're lucky when we can get 0.5 as an effect size for a lot of other things that we treat. And some of these studies involved looking at daytime symptoms, like such as the hyperarousal, avoidance, numbing, re-experiencing. Those all had effect sizes just under 1. So this is how things started. A 4th study also had excellent results, a little bit larger, 67 patients. They had a number needed to treat of 2.7 versus placebo in this trial. All outcomes strongly favored prazosin, no difference from placebo. But then came the Raskin et al. 2018 study, which convinced many people that prazosin does not work because it was large, multi-center, VA-sponsored. It's very hard to get anything to work in VA studies, by the way. They're a very tough group of patients. They don't respond well to schizophrenia treatments, depression treatments. However, they didn't respond in this study to prazosin. But many reasons have been proposed by the authors and editorialists for why this study was not positive. One of them was that they all had normal blood pressure. They were also very careful to exclude a lot of other comorbidities and issues that were not excluded in the other studies, so they were a very nice group of relatively mildly ill patients. So that's why, despite this one negative study, we have 6 positive studies, we have the meta-analysis, and we think it's the best option for PTSD. Now, you should contrast that with the evidence on sertraline, one of the FDA-approved antidepressants. That's had 2 large randomized control trials versus placebo in veterans, both showing no difference from placebo for sertraline. Plus, there are 2 unpublished large civilian studies on sertraline that were also negative. So sertraline was very lucky to get FDA approval with this evidence base as a treatment for PTSD. And in England, sertraline is only approved for PTSD for women. In their analysis over there of the data, they decided that it worked for women but not for men. They thought gender was more important than veteran status in explaining the poor results of the VA studies. So they approved it for women but not for men. And at the bottom you have the other positive and the 2 other negative studies. Now, another thing that people don't know about prazosin, aside from the fact that it works and might be your first-line choice, is how to dose it. And that's why I have these 2 slides on how it was dosed in the studies where it worked well. If you want to practice evidence-based medicine, you can't just go by whether a drug worked. You have to prescribe it in the way that it was prescribed in the studies where it worked. I have a tough time teaching this point because everyone seems to want to invent their own way of prescribing prazosin. And studies have shown that in the VA, 90% of patients are underdosed when they get their trial of prazosin. So that may be why some people don't have confidence in it. But here's the dosing for prazosin that works, which I use, and others who are in the know about the evidence base of this use and report to me, at least anecdotally, that they think it works. So here's how it starts. This is for men. There's different dosing for men and women. For the men, the night dose starts with 1 milligram for 2 nights. Then you go to 2 milligrams for the rest of the first week, making a total of 7 nights. Now, I see all the time people are being prescribed prazosin. They'll be started on 1 milligram, and they give them an appointment in 1 month to review how that worked. Now, the patient who takes it for 1 month at 1 milligram and doesn't notice anything doing better is not impressed with this drug at all, may quit taking it after 2-3 weeks and tell you that it just isn't working. And when I read notes of these situations, I see the clinician accepting that, saying, okay, you say it didn't work, fine, I'll move on to plan B for you. Because that clinician doesn't know what's on this slide, that you're only supposed to stay with 1 milligram for 2 nights. Then for the second week, you go to 4 milligrams. For the third week, 6. For the fourth week, 10. Meanwhile, you're graduating to higher size capsules. Comes in 2s and 5s. 15 and 20 was the maximum in this particular study by Raskin 10 years ago. The median dose that produced optimal benefit and was tolerated was 15.6 milligrams. That was the median dose. That meant half of them needed more. Now, after they've been started and are tolerating the prazosin at night, you can begin some daytime prazosin. And you can see that on the right. Starting with week 2, you can start with 1 milligram, then you go up to 2 for a couple of weeks, then you go to 5 from weeks 5 and 6, because that may give additional benefit on the daytime symptoms, in addition to whatever you get from improving their sleep and having more restorative sleep, which can carry over into the day. Here's the titration for women from the same study, and you can see that it's a little slower and less with women. They start with 1 for 2 nights also with the women, but then they go to 2 milligrams for the rest of 2 weeks, 12 nights more, and then they go to 4 for a week, 6 for a week. 10 was the maximum they used in that study. The median dose that was effective for the women was 7. And then they do a mid-morning dose and go up to 2. There's been no explanation for why doses are lower in women, but it's not always the case. There is case reports published for 2 women by Kula and colleagues in 2014 where they went up to 30 and 45 milligrams. Can you believe this? A woman got 45 milligrams at bedtime, tolerated it, and did better when getting to that dose. I sometimes mention that to patients for whom they think, gee, it seems weird to have to go to 10, 15. Not because I'm going to need to go to 45, I never have, but just so there's some perspective that there's a wide range of tolerability of this drug that's very hard to predict. Some will be dizzy on 2 or 4 milligrams, and others can tolerate remarkable doses and be walking around showing no sign that it's having any side effects. Okay, so this is a key part of the algorithm that I think changes practice. I've already given you my core recommendations, but there's a few more to come of maybe more minor significance, so I'll press on. So first of all, what if they don't have nightmares, disturbed awakenings, night terrors? The only problem is they have trouble falling asleep. What do we recommend then? Well, our first line choices, when you need something to get you over the hump and getting you to sleep, is hydroxyzine first and then trazodone second. Why hydroxyzine? Because it has the only randomized controlled trial in PTSD for initiating sleep problems by this paper by Ahmad Pana, if I'm pronouncing it correctly, 9 years ago now. He published a very interesting 3-way study in about 100-something patients where they got either placebo, hydroxyzine, or prazosin. And the results were that prazosin was much better than placebo. That's one of the positive studies. But so was hydroxyzine. But hydroxyzine was not as good as prazosin for the overall PTSD studies. But for falling asleep, it was helpful. So that's why it is our first line recommendation. Now, our second line is trazodone, and that used to be first in our earlier papers, but it really has had no controlled studies in PTSD. So it's purely from clinical experience. So we've knocked it down in our algorithm because we always prefer, when we have randomized controlled trials supporting something. Now, you can also add hydroxyzine or trazodone if they got treated for their nightmares and disturbed awakenings and you had good results, but they still can't fall asleep. Then we would consider adding hydroxyzine or trazodone. And another up-and-coming option is clonidine for this purpose. Clonidine also has no placebo-controlled trials in PTSD, but it has a pretty large case series by Burek from a couple of years ago, 90 patients in Chicago VA, and of course it's uncontrolled. We need placebo-controlled, but they had quite impressive results, and they have a placebo-controlled trial underway right now. So we're eagerly awaiting those results. So we have it as a third-line option, though, for helping people fall asleep. It's much more sedating than prazosin, but also more hypotensive. And here is that Burek study. They found 72% getting improvement on the CGI. I'm sorry, it was 79 patients in their clinic, of whom 49% were much improved or very much improved. So that's pretty good results. The dose was 0.1 to 0.2 at bedtime to start, and also they offered it PRN during the day at a half of that dose, so 0.05 milligrams, up to 3 times a day. They also transitioned some of their patients to a clonidine patch with good results, again, uncontrolled. But as you can see from the star below, there's actually 2 large crossover studies currently underway, both by Burek's group, and also a group in Norway has a study underway that we heard about. All right, here's a list of undesirable choices in case you don't like our suggestions for treating the sleep in these people. Here's what we think of the other options. Tricyclics actually have a long history. Amitriptyline was the first FDA-approved treatment in the US for PTSD. It's a sedating tricyclic, probably the most sedating of the group. Well, I'm not sure. Chloromapramine is pretty sedating too. But overall, they've got way more side effects than the other things we're thinking about, so we think they're undesirable. Quetiapine, sedating, of course, very commonly used. I have another slide on that. And then I'll skip to benzodiazepines. Alprazolam has actually been studied in PTSD. It did not beat placebo as a treatment. And the benzos in general have very high potential for abuse by patients with PTSD. And another negative about them is they reduce short and long-term effectiveness of exposure therapy. It doesn't work as well if they're on a benzodiazepine. That's another negative. And often we want some concomitant psychotherapy such as exposure therapy. And one Z-type drug related to the benzodiazepines, S-zopiclone, had a positive study in PTSD for sleep, but then that was followed by a firmly negative study 3 years ago by Germain and colleagues. So we think that's not on the radar as a treatment. Now, should quetiapine be used as a hypnotic? Various meta-analyses or reviews of the evidence conclude that benefits do not justify the risks, and it shouldn't be used, certainly not as a first-line treatment for any kind of insomnia. And I'm sure you know the side effects: weight gain, the famous Seroquel munchies, metabolic side effects, and they're not dose-related. You can get all of them at 25 or 50 milligrams. There's also dose-related cardiac side effects, QTc, prolongation, and it does have a risk of causing tardive dyskinesia, up to 2% per year. And in the bottom, I just have this study from the VA where they looked at outcomes of people treated with quetiapine, 175 people in this VA, versus a bunch treated with prazosin. Way more discontinued their quetiapine due to side effects than the prazosin group. Okay, now you have completed the assessment and management of sleep difficulties. You've considered what we approve, what we don't approve of in our algorithm. Now the next step is to see whether there are significant remaining PTSD symptoms. And if so, then addition of some medication with a broader spectrum of efficacy for PTSD may now be considered, and as suggested by many others, SSRIs would be first line at this point. So have you tried an SSRI, is our question at this point in the algorithm. And you know about the paroxetine and sertraline being FDA approved, but how good is the benefit? Well, it turns out the overall effect size by standardized mean difference in meta-analysis is 0.23. That's it. It's almost clinically insignificant, even if it's been statistically significant. And of course, SSRIs have a variety of undesirable side effects, like sexual side effects, which could be impacting anywhere from 30 to 70% of your patients. Everybody hates those sexual side effects. So, gee whiz, if you don't need to use them and you've got some alternative, you should certainly be considering it. There's other side effects too, insomnia. It can be a side effect even of paroxetine, which is said to be more, it makes you tired, but it's actually not more sedating than the other SSRIs. And it sometimes has the opposite effect of making sleep worse. And then there's the anticoagulant effect. It makes GI bleeding worse. If you're having any procedures, on the surgical procedures, it could be an issue. And I already told you that it's not approved for men in the UK. This little graph from the NICE guidelines, from their latest meta-analysis and review of SSRIs for PTSD, these are the places where they put the paroxetine, fluoxetine, and sertraline data. See on the left there? They're all below the 0.5 effect size that they consider the start of a clinically meaningful benefit. 0.8 is considered clinically important by the NICE group, National Institute for Clinical Excellence. And look at how tiny they are. Paroxetine is the best at 0.41, but it has the disadvantages I've already mentioned. Sertraline could be as high as 0.26, and fluoxetine is the same or worse as sertraline. Prazosin was not evaluated in the NICE guidelines. Their studies were too small to be considered. But here's about where it would be if you at least considered those first 4 studies that I showed you. It'd be way up here above the 0.8. And in doing this latest update of our paper, we reviewed what's new since our last paper. Any new studies of paroxetine and sertraline since our last review, or we said the same thing about 10, 11 years ago in our previous publication. And nothing really new here, same effect sizes. We did find in this review that by Hoskins at the bottom that he found 3 unpublished negative studies, 1 in veterans and 2 in mixed trauma cases, all never published, all negative on sertraline. Now, as far as other SSRIs, a couple of more studies here. Here's a sertraline study from China where it had a positive results on the CGI, and this study by Zollner in civilians found a little bit higher effect size than all those other studies. So that was a little point in favor of sertraline from that newest set of data. But nothing new on fluoxetine, citalopram, or escitalopram for our review. Okay, the next issue is, what if you try your SSRI and you get no response? Well, we have 2 branches of the algorithm at this point. If they have psychosis present, psychosis due to the PTSD, then you're on the right side of the chart. I'm going to show you what we recommend there. If they don't have psychosis and they didn't respond to the SSRI, then you go down the left side where we're recommending some additional antidepressant trials. So let's look at the psychosis issue. So what are PTSD-related psychotic symptoms? Well, in veterans, for example, it might be hearing hallucinations of hearing soldiers screaming that they saw on the battlefield that they were in, who were in agony, and that has come back as an auditory hallucination. They don't have any primary psychotic disorder, but they have hallucinations that clearly relate to their PTSD. They also may have visual hallucinations of some attacker. And they may have non-bizarre delusions also that are seemingly related to their trauma. So what do we recommend? Well, we think you should add an antipsychotic to the SSRI. We have you use an SSRI first because some of these psychotic patients with PTSD, the psychosis will improve on the antidepressant. But if it doesn't, then you're at this node of the algorithm, and we're recommending adding an antipsychotic. And the one with the best evidence is risperidone, because that has the only placebo-controlled randomized trial. And again, we favor in our algorithm when there's that kind of evidence. Others may be better, but that's the one that has the study. Hamner was an open label. Then there was Rothbaum's placebo-controlled trial with a positive result. There's also open label work with quetiapine and olanzapine as the add-on. Now, quetiapine had this study by Villarreal which had a mixture of people with psychotic and non-psychotic PTSD, and they didn't separate out the results for those two groups. They're mixed together, so it could be taken as a study showing a benefit for positive symptoms, for psychotic symptoms, but the study really doesn't delineate that. So we do mention it here, but I have this little caveat at the bottom. You can probably read it. One always wonders in double-blind studies of quetiapine whether the blind was successful. The obvious side effects of quetiapine, of the sedation, and the munchies, the appetite increase 30 minutes after taking it, make it very easy to know if you were randomized to it. In any of the studies for bipolar depression, schizophrenia, and in these PTSD studies, you always have to wonder, did the patients know what they were on? It makes a big difference. If you know you're on the drug and you didn't get the placebo, this is a joyful thing. You volunteered to be in the study, and wow, you're getting the drug. Your luck didn't fail you, and you didn't get put on the placebo, which you're now going to have to take for 6 weeks and expect nothing. Instead, you know you're on the drug. Now, the drug companies virtually never ask patients what they thought they were put on, because if they had data on that and it invalidated their study, it could waste all the money that they spent on that study. So they never ask. But it's a good question whether the positive results with quetiapine in blinded studies with placebo are successful blinds. And actually, even aripiprazole might be considered first over the risperidone, much less the quetiapine, because of a more favorable side effect profile. Like I said, in our algorithm, we consider evidence of effectiveness, but also side effect profile in deciding how to sequence things. And aripiprazole has these several uncontrolled studies. Well, no, 2 uncontrolled studies, 1 randomized trial, which was not significant. So it's not impressive about risperidone that it didn't beat placebo in this 16-patient study. But the other data is kind of impressive, so we wouldn't object if you wanted to do aripiprazole as your first add-on to the SSRI. Okay, let's move to the left side of this second half of the algorithm, where we're considering people who failed on the first SSRI. And what do we recommend you try next? Well, we would recommend try another SSRI, or you could try an SNRI, and both of them have controlled trials, venlafaxine and duloxetine, or at least 2 of the 3 SNRIs we have available in the United States, have this positive data. The negative thing, though, about these 2 drugs is they had no benefit for hyperarousal symptoms of PTSD. No nightmare reduction from either of those treatments. We think that's because both drugs have this adrenergic component to stimulate norepinephrine. That's probably a bad thing for someone with PTSD. And it may be the reason why no hyperarousal or sleep problems improved on these 2 drugs. And that's why we've put it at the second level after you've tried an SRI as something to consider. They did work overall on some symptoms, like re-experiencing and avoidance, though. Now, you might wonder, how come we didn't mention mirtazapine so far at this node? It could work as an augmentation of your SSRI. We have 2 studies of that. They added mirtazapine to sertraline with some improvement in one study, and they added it to paroxetine in another study, which is convenient. The 2 FDA-approved treatments have both had add-on studies. However, there is a mirtazapine monotherapy study versus placebo showing no efficacy. So if you're thinking of it as a monotherapy at this juncture to replace what you've been on before, we don't have any solid evidence to back that idea. All right, now we're at node 5, and that's the 3rd medication trial. What should you do then? You've tried 2 antidepressants. What's left? Well, you could consider another SSRI not yet tried. You could consider another SNRI not yet tried of the 2 I showed you. And if you haven't tried daytime prazosin yet for their daytime symptoms, this would be a good time to consider it. And also clonidine may be used this way, as it was by Burek. And we'll see how his placebo-controlled trial goes and the Norwegian study to see if it might go up higher on this slide as a recommendation. All right, so what's left? We're at the bottom of the algorithm for treatment-resistant cases. So I have some remaining options that are listed in a table. And it may be hard to see that table. I'll explain it a little bit. But the supporting evidence ranges from unconvincing to, in some cases, fairly robust. And here's the table. Again, I apologize for the difficulty seeing this, but at the top, we have mood stabilizers that have been used in PTSD. And it starts with valproic acid. So after a positive open-label study over 30 years ago, we have 2 placebo-controlled trials of valproate for PTSD, both firmly negative. Now, I know a lot of people think of valproate as the all-purpose drug for anyone who's agitated, irritable. That's how I see some of my colleagues using it. Well, if PTSD is what's causing those symptoms, the evidence base is pretty close to 0. You should be looking to the other things we've recommended. Now, on the other hand, lamotrigine does have one somewhat positive study, and if you've got a patient with bipolar disorder and has issues with bipolar depression and PTSD, this might be a good option to consider. Topiramate is another mood stabilizer. There have been 3 studies of it. 2 versus placebo, no difference. But then the most recent one, 12 years ago, from Brazil, on 70 patients, found a substantial difference from placebo on the CAP score, 58-point improvement on the topiramate versus 32 on the placebo, with a large statistical p.008. So I think topiramate may work. It seems to work in Brazil, but it's not deserving a higher place in the algorithm, given the 2 negative studies. Now, the rest of these anticonvulsants are not worth mentioning. We have little or no evidence on them. And on the right, we have the antipsychotics. I've actually discussed them pretty thoroughly as it applies to the situation where they are having psychotic symptoms, so I won't repeat that. But then at the bottom, we have some other agents. Guanfacine has been used. There have been 2 randomized controlled trials of it. One of them with one of my colleagues at my hospital being one of the investigators, and both of them had no difference from placebo. So I wouldn't go there. Now, clonidine, which is the short-acting way of doing what guanfacine does, there is this equivocal data in the controlled studies and more underway, so we will see where that goes. The MAOI phenelzine has some evidence. Plus or minus is how we rate it. Certainly has a lot of side effects. And doxazosin, which is another drug similar to prazosin, had a positive study that was exciting to us. We thought it needed more study, though it doesn't cross the blood-brain barrier very well. It does cross it some, though. Not as much as prazosin. But then, Back et al. Just published this year a larger 141-patient placebo-controlled trial showing no efficacy at all to doxazosin. So we've dropped it off our mention list in higher up in the algorithm where we used to have it. But we still retain it in the table here. And finally, the further options beyond these, there's some evidence that transcranial magnetic stimulation may have a role in PTSD. I think this is up and coming. It's very exciting. We could use more data on it. CBD, a component of cannabis, may have some benefit. Ketamine might have some benefit, just small evidence on it. And stellate ganglion block. None of these, though, did we think have sufficient evidence for higher placement in the algorithm. And as far as cannabis goes, which I know is very popular out there among our population of veterans as a treatment for their PTSD, but I'm very impressed with how it's not doing well in the placebo-controlled trials. For example, this study by Bon Miller and colleagues 3 years ago, they looked at 3 concentrations of smoked cannabis versus a placebo-smoked product. So the 3 concentrations, one had high THC and low CBD. The second one had low THC and high CBD. And the third smoked product was high with both. And then there was a placebo smoke. And they smoked these things for 3 weeks. No difference from placebo on the 3 methods of administering cannabis by smoking it. So I have a tough time persuading my veterans who are addicted to this drug that it's not effectively treating their PTSD. I think what it does is while they're getting high from the cannabis, temporarily, for a short time, they feel less anxious. Then it wears off, and they're worse than they were before they started using the cannabis, but they can salvage that by smoking some more. So they're convinced that it works, but it doesn't. And in fact, some studies show increased anger and irritability. The Wilkinson study in 2015 found that the cannabis users are more angry than the comparable ones not using it. And MDMA enhanced psychotherapy of PTSD in one study. That's an interesting direction that we are not covering in this talk. Enhancement of psychotherapy with various products. So in summary, our algorithm proposed in 2011 that the first-line med for PTSD that features prominent nightmares and disturbed awakenings might be prazosin before an SSRI. In 2023, this recommendation still seems based on a reasonable interpretation of the current evidence, and other anti-adrenergic agents like clonidine seem promising, and we're watching them. But the standard treatment with SSRIs and SNRIs have actually only minor benefits. And again, here's the place to find our website, psychopharm.mobi. Teshakura.